Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
This is my financial disclosure. And the disclaimer that I know HRSA doesn't want us to use brand names, but it's really hard to avoid brand names. It gets to be a mouthful. But so only for training and identification purposes only. So today I want to go over some of the newer options for hepatitis B immunization and review some of the efficacy data, particularly with respect to key subpopulations of patients, including people with HIV, and wanted to spend some time talking about our current understanding of the role of antiviral therapy in Hep B prevention. Despite the fact that it's been over 40 years since the original plasma-derived Hep B vaccine was first licensed in 1981, hepatitis B remains a major public health issue and is still a leading cause of liver-related deaths worldwide. Globally, chronic Hep B accounts for 43% of cases of hepatocellular carcinoma and 40% of cirrhosis, with a much higher proportion in lower middle income countries. So the rates of Hep B vaccine uptake have also been suboptimal across the board, regardless of the patient population or setting you're really looking at, to the point where the U.S. Advisory Committee on Immunization Practices has now recommended a more universal rather than risk-based approach to Hep B immunization for adults. So let's start off with our case. So this is a 25-year-old man with HIV, a CD4 count of 190, virally suppressed on tenofovir, emtricitabine, and dolutegravir, who's coming in for routine care. He's had multiple male partners in the past 2 months and would like to get some STI screening. And our review of labs, you note that his core antibody, surface antibody, and surface antigen are all negative. So I won't read the answers. I'll let you read them, but go ahead and submit what you think we should do next. Okay, so it looks like the majority of you want to go ahead and immunize with the CpG adjuvanted Hep B vaccine. Almost a third of you think that we should do the double dose recombinant. And then a small portion actually think we should wait until CD4 count gets above 200. So great. This case is really a launching point to review the newer Hep B vaccines, which are both no longer considered investigational and currently licensed in multiple countries. Heplisav-B was licensed in 2017 and PreHevbrio in 2021. Neither vaccine is yet licensed for people with HIV. So let's review the CpG adjuvanted Hep B vaccine first. So CpG DNA is basically a synthetic oligonucleotide, so a little piece of DNA that's comprised of a cytosine and guanine, and it has distinct immunostimulatory properties for our innate immune system. It binds to toll-like receptor 9 of B cells and plasmacytoid dendritic cells, initiating a signaling cascade that results in cytokine release and adaptive immune responses. So CpG is actually being considered for a bunch of different immunomodulatory functions, including cancer treatment. But at the moment, the most developed role is that of a vaccine adjuvant. So HBV 23 was a phase 3 observer-blinded active control trial to look at the immunogenicity of CpG adjuvanted vaccine compared with the standard alum adjuvanted recombinant vaccine in adults 18 to 70 years of age, and who were randomized 2-to-1 for active and control across 40 sites in the US. In this study, people with HIV were excluded. And a key goal of this trial was to evaluate the efficacy in persons with diabetes. So this study population was enriched for individuals with diabetes, and they numbered over 1,000. And part of this was because those with diabetes have approximately twice the risk of acquiring Hep B, as well as having a greater risk of developing complications, including chronic infection, liver disease, and HCC. But they've also historically had lower response rates to recombinant vaccines compared with healthy adults. The endpoints of the study were seroprotective response, which is a surface antibody titer of 10 or greater, in those with diabetes, as well as the overall study population. So in the end, they had over 5,500 in the HEPLISAV-B arm and over 2,700 in the control arm, well matched in baseline characteristics. This was an older population with a mean age of 50, most of whom were white or black. Body mass index was on the higher side, with just under half meeting the obese category, and a third were smokers, and over 13% had diabetes. Ultimately, HEPLISAV-B arm was found to have a higher seroprotective response rates across the total study population, as well as within different age categories compared with the standard vaccine, with the most pronounced difference in response rates seen in the oldest cohort, those over 60. This also held true when examining seroprotection rates across subgroups defined by key comorbidities, specifically diabetes, obesity, smoking, with the greatest difference seen in those with diabetes. So the differences between the CpG adjuvanted versus the standard vaccine across key subgroups are shown in this forest plot, and you can see that the confidence intervals favor the newer vaccine. So the question arises, how will this perform in people with HIV? So people with HIV have historically had suboptimal seroprotective responses to standard recombinant Hep B vaccine, with pooled rates of about 65.5% for the standard 20 microgram dose in this meta-analysis, and just over 75% for the double dose, which stand in sharp contrast to healthy adults whose response rates are typically in the range of about 96%. So we now have early efficacy data from the Beehive trial, which is a phase 3 single-arm open-label trial in multiple countries involving 2 cohorts. So Group A are non-responders to prior immunization, and they're still enrolling. So what the results I'm going to show are not Group A, but Group B, who are vaccine-naive participants. So Group B results were presented this past October in ID Week. Beehive used the same dose of HEPLISAV-B that's used in the general population study, but instead you'll note that the schedule here included 3 doses spaced similarly to the standard alum-adjuvanted vaccine at 0, 4, and 24 weeks, as opposed to just 0 and 4 weeks. So that's a key difference worth noting. Baseline characteristics of the 74 participants with HIV are shown here. And in contrast to other studies, Asians comprised 2/3 of the cohort, as Thailand and Vietnam were among the countries enrolling for Group B. And this vaccine-naive group also had a high median CD4 count of 625, and all but a few were virally suppressed on antiretroviral therapy. So here are the results. This bar chart shows the seroprotective response rates at each of the study time points. So any shade of blue here represents those whose antibody titers met the 10 IU per liter threshold for seroprotection. Notable finding was that the antibody check 4 weeks after the second dose, I'm just going to call that out, had an 87% response rate that interestingly increased by an additional 11% to greater than 98% before the last dose was even given. So just something to note. The darker blue here represents those whose antibody titers exceeded 1,000 IU per liter, which I'm just going to let that data sink in for a moment, because this is a rare outcome, as many of you clinicians know, with standard recombinant vaccine, particularly in those with HIV. So not only was there a 100% overall rate, but over 83% of recipients achieved this very high titer after the 3rd dose of HEPLISAV-B. So the safety outcomes were also reassuring. 40% experienced injection site pain, which is comparable to what was observed in the main registration trial, and all adverse events were grade 1 and 2 in severity, aside from 1 case of malaise, which was grade 3. So let's switch gears and review the data for the novel tri-antigen Hep B vaccine. So this is an alum-adjuvanted vaccine, much like the standard vaccine, but contains 3 distinct hepatitis B surface antigens derived from mammalian cells. In addition to the S antigen, it contains pre-S1 and pre-S2, which together resemble the naturally occurring Hep B viral particles in terms of protein composition and glycosylation, thus, in theory, providing a broader array of epitopes for the immune system. The PROTECT trial was a phase 3 double-blinded randomized controlled trial conducted at multiple sites in the US, Finland, Canada, and Belgium that looked at the safety and immunogenicity of this triantigenic vaccine compared to standard vaccine in naive adults. Those with HIV were actually excluded. And like the HBV23 trial, this study population also spanned a broad range of ages. 90% of participants were white, under 8% had diabetes. So at each stage of the assessment, the triantigenic vaccine was found to have higher seroprotection rates compared with the standard arm, meeting the pre-specified threshold for non-inferiority and superiority. And ultimately, at 4 weeks after the last dose, the difference in seroprotective response rates was found to be close to 15%. In addition, the geometric mean concentrations of surface antibody were also 5 to 8-fold higher in those who received the triantigenic vaccine compared with the control arm. The triantigenic vaccine also had a notable advantage in older age groups. Like the CpG adjuvanted vaccine, its immunogenicity wasn't impacted by advancing age as much as is the case with standard vaccine. This advantage also seemed to hold for the comorbidities as well, as you can see the differences for patients with obesity, diabetes, and smoking. Safety data shown here suggested comparable systemic effects. Local reactions appear to occur more often in the triantigenic vaccine. And at this time, unlike Heplisav-B, we actually have no trial data for pre-Hevbrio in people with HIV. And I don't actually see that one is currently planned when I last checked on clinicaltrials.gov. So the potential role of this in HIV care setting remains unclear. So going back to our case, I did want to take a moment to explore the idea captured in Answer C, which is this concept of tenofovir as chemoprophylaxis against Hep B infection. So it's worth noting at this time that we have robust data to support the use of tenofovir for HIV treatment, HIV prevention, and Hep B treatment, but no trial data to support this concept of Hep B antiviral prophylaxis, at least in non-pregnant adults. What we do have, however, are a number of observational studies in men who have sex with men with or without HIV that suggest a protective effect when used in the context of ART or PrEP. The magnitude of this effect size when you evaluate the larger studies ranges from anywhere from 60 to 90% reduction in Hep B infection rates compared with no antiviral therapy. And there is some suggestion from this Dutch study that the protective benefit from lamivudine in the absence of tenofovir may not be quite as robust. Overall, I don't believe this is sufficient evidence for discarding immunization in favor of antiviral prophylaxis, as might be suggested by Answer C, particularly when you think about the fact that we have to rely on daily consistent adherence to an oral drug compared with a few vaccine injections and years of presumably lifelong protection. And I would stress this point because in the MAX study, Dr. Falad Noulia showed that this protective benefit was not observed in individuals who were supposedly on ART, but having HIV viremia, so essentially not taking the medication. The best evidence at this time for tenofovir as HBV chemoprophylaxis comes from the perinatal setting. In this trial, 200 pregnant women with chronic hepatitis B and high viral levels, and they used a threshold of greater than 200,000 IU per liter, were randomized to undergo usual care alone, which included the receipt of Hep B immune globulin and birth dose vaccine in the infant, versus usual care plus tenofovir disoproxil fumarate initiated by the mother in late second trimester through postpartum week 4. So TDF was found to be effective in reducing maternal HBV viremia enough to interrupt HBV transmission even further than with immune prophylaxis alone. It is worth noting here that the modality tested is really treatment as prevention, I would say, rather than Hep B pre-exposure prophylaxis, which is sort of the notion that was captured in Answer C. But I do think it's worth noting that tenofovir does provide some protection from Hep B in adults, and that this protection can be lost with a switch in ART, as illustrated in this report of a young man with HIV who was enrolled in the FLAIR trial of cabotegravir and rilpivirine. Prior to the trial, he was actually found to be Hep B susceptible and had received immunization with the standard 3-dose recombinant vaccine series. 9 months into the study, he was found to have acquired acute hepatitis B with evidence of surface antigen as well as core IgM antibody. And his archived serum 5 months after completion of the vaccine series was tested, and it basically showed that he had not developed seroprotective immunity. So I bring up this case and the concept of antiviral prophylaxis because we are essentially entering an interesting era of Hep B prevention versus / protection, which is that more of our patients may be on tenofovir sparing regimens. So this is something that you have to consider. So not only consider it from the standpoint of chronic hepatitis B and HBV reactivation, but the fact that they, particularly those who, may not have mounted a seroprotective response to vaccine, like we might have to think about figuring out ways to protect them once again. But it is an exciting time because I think, with the CpG adjuvanted vaccine, I think our Hep B prevention, the OI guidelines are probably going to look different in the coming years. So I do think that you should stay tuned. I also wanted to, in the minutes remaining, just remind everybody that, we do have a number of resources in addition to hepatitis C online, which is the more well-known cousin. We have hepatitis B online, which has a number of different lessons that cover in a lot more detail what I covered today, and a lot of the data slides I really got from this site. So do check it out, and I'm happy to take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.